So what I'm going to talk about today is how a generally recognized principle, such as autonomy, becomes more and more complicated the closer you look at it. And although I'm going to talk about it in the abstract and in theory, the complications I'm talking about appear when one looks at the issue empirically. So I'm going to talk about some preliminary empirical work I've done with others to look on how autonomy really, where the autonomy meets the road, empirically speaking. So in the first couple of slides, I've included in the background images of books that have meant a lot to me in understanding autonomy and the complications of autonomy. One work that's meant a lot to me is the practice of autonomy, where actually a lot is done both on a theoretical and empirical basis to do what I'm trying to do in a preliminary way in my own work, and that is to examine the complications of the actual practice of autonomy. So in this slide, I'm talking about Schneider's, the standard view as he quotes it. He is by no means uncritically accepting this. This is just a formulation that he gives, which I think is an accurate formulation, and we can talk about to which groups it more often applies or not. So the physician's role, according to what you might call a naive or uncritical view, is to use their training to provide the patient with facts and alternatives in care. And the patient's role is to provide the values to evaluate those alternatives, and the role is also to select. Right? And that, in fact, I think that's a widely held view. And what follows, we're going to push on that a little bit. So if that's the case, if that's how things should work, what we can do is we can just get on with it, right? We can remove impediments to autonomy, and we can let patients practice it. How do you get to the Carnegie Hall of Autonomy? Practice, right? So once impediments to autonomy are gone, again, Schneider is quoting, not necessarily his retweet is not an endorsement, people will naturally gather the evidence about the risk and benefits of each medical choice, apply their values to that evidence, and reach a considered decision. Now, in the very concatenation of the phrases here, you realize that if you actually think about when each of these phrases applies and to what degree and for what populations and in what circumstances, you realize how complicated this assumption really is. In fact, I think this is one of the, not perhaps one of the greatest unrecognized works of art, but I think one that reveals some aspects nevertheless. First of all, we realize that the gentleman on the right is not, in fact, currently making the decision, right? Second, we realize that the physician on the left is not necessarily recognizing the patient's autonomy. But third, we realize by the gentleman on the right that by his countenance, that he's not perhaps prepared even to exercise autonomy were the possibility were provided him. So that's sort of in a nutshell what we're talking about. When patients feel like or feel adequate to exercise autonomy. So this is the question, right? How is autonomy exercised in practice? And Schneider has a great chapter where he reviews the empirical literature about how often patients actually would like to make decisions. And one quote he brings from a patient from one of these studies is, and in fact I could cite this word for word as a quote that's often in the mouths of people I see in my practice. I don't know anything. How am I supposed to decide, right? So what Schneider argues against in his book, and I freely admit his term is a red herring, so no one goes around calling themselves, or at least I hope not, a mandatory autonomist. Well, A, because that'd be an oxymoron, right? Right. But which I think is part of the larger point. But B, just because it sounds bad, right? But there are people who are perhaps more thoroughgoing in their advocacy for patient autonomy. We should expect, according to these people, which are thick enough on the ground that I don't have to say who they are in particular, but we should expect that all patients exercise autonomy. Basically, the ideal is that autonomy is exercised. The sub-ideal is that it's not, and we want people to get there. We want everybody to get there. Not we want people in general, we want everybody to get there, right? If we don't see autonomy, we should ask why it's not there and rectify the situation. And he brings several arguments. Although the theoretical underpinnings are not the focus of my talk today, I think it's useful to think about these in detail and then to try, when I talk about data later, to see how these apply to the data. So there's the prophylactic argument, not about contraception, although that's another interesting topic, but that the idea being that doctors, my kind, tend to be non-autonomy appreciative, right? Paternalistic. And so it's up to the patient to be on their guard, to have the autonomy shields up, to use Star Trek lingo, right? And be wary and be watchful. The next argument is that there's a therapeutic argument that in certain clinical entities, in certain clinical situations, for certain types of people. Let's scratch that. The person that takes a more thoroughgoing approach would say that in general, for most people, or even for all people, if you're more autonomous, you're going to get a better clinical outcome. We'll talk about the limitations of that in a moment. There are two other arguments. One is the argument by false consciousness. Even those people who don't want to make a decision, right? You're the doctor, please decide for me. I get that a lot. Or people that would just rather not exercise their autonomy in a so-called full way. They're operating from a place of false consciousness. Now, obviously, there's a broad historical literature on false consciousness, which I'm not empowered to deal with, but in general, the argument is they don't know what they should want, right? And then there's the moral argument from authenticity, which really is founded on the basis of understanding a patient's so-called true self as a self that makes autonomous decisions. And that when a patient exercises autonomy, they're coming back to who they really are. And that's the person when participating in care, that authentic true self. And then what Schneider does, which I think is great, is he sort of stands them all up, and he doesn't knock them down, but he subtly undermines them by going into detail about limitations and what actually happens, stuff I'm going to talk about later. So for the prophylactic, for each one of these, he says, yeah, sure, but not all the time, and not that much, and not to the exclusion of other things. That's his general point. So the prophylactic argument, yes, doctors can be, to use a technical term, jerks, right? They could not appreciate patients' autonomy. But we know, of course, that the culture has changed a lot. We know that many physicians are patient-centered to a fault, right, for example. Even for the therapeutic argument, there are areas in the literature for which we know that patients that are more autonomous get better clinical outcomes. There's some evidence in diabetes, for example. But again, we know that that's limited evidence for a limited set of outcomes, and not for everybody and not all the time. Again, the false consciousness argument and the weakness I think that Schneider points out to that too is that sometimes it's not false, right? Sometimes there are people who do prefer not to exercise autonomy at certain times, and that plays into the weaknesses of the last argument, that in fact it's not true all the time, that someone's true self is there as reflected by only an autonomously made decision. I'm going to talk about this in the next slide, but in short, no person, one could argue, or very rarely does one make an unassisted, completely sole decision, right, without the help or the involvement of other people. And the other point that Schneider makes is that there are other principles to be balanced, right? There's autonomy, but there's also the liberty, right? The freedom to not make a decision at a particular time. Right? There's community. There's other principles that go into medical decision making. So what I'm going to talk about, and what I hope my empirical work tends toward, is the encouragement of autonomy. Encourage autonomy, in the quotes indicating that I made it up, means we want to assess patients' readiness towards various domains of autonomy, and we want to encourage good exercise in those domains that apply for those people that prefer. So for that to be the case, we'd like to look at broader definitions. And again, I'm not going into detail about the theoretical underpinnings, but there are some options. What I think the more thoroughgoing autonomists would really care about most often is decisional autonomy, really taking part in medical decision making, right? Really knowing what the risks and benefits are with regard, for example, to various routes of managing gallbladder stones and what to do about it, right? And really making that decision on an informed basis. But there are other sorts of autonomy that we should care about. There's what Gerald Dworkin calls second-order autonomy, right? The ability to make downstream decisions unfettered by outside constraints. And then what I'd also like to talk more about, and we're going to go into more in my data, is relational autonomy. Autonomy, as I pointed out just a little bit ago, is never really exercised in isolation. When a person is provided with social support and recognition, they can affect her capacities for self-trust, self-esteem, and self-respect, and that affects the patient's ability to exercise autonomy. We know, in fact, from our own experience, either as providers or as patients or as relatives or loved ones, that when people are in the hospital, it's precisely those things that can be undermined and which undermine their autonomy. And it's not because patients, one could argue that often in the hospital, it's not because patients' authentic self goes unrecognized. That's not the reason they're unable to exercise autonomy. It's because they're lacking those relationships, right, that make it possible. So I think the general point here is that, there are as many different kinds of patients and patient situations as there are people. And this is another work about patients, about autonomy in the hospital, which talks about how actual situations can force us to reconsider the meaning or content of a concept. That's why ethical vignettes are great, and they really help us, hone in on the principles at issue. But as anyone knows, it's been on a consult service of any sort. People don't read the books, right? Patients don't read the books, and situations aren't as neatly laid out as they might be. So when we go into a situation, we see the details and we see how people act. That can cause us to re-examine our attachment to various principles, to not abandon those principles, but to make them more nuanced and modify our approach to them. So what I'm going to talk about with regard to our empirical work is how do we encourage autonomy, not demand it, but encourage it, in clinic and in the hospital. And what I'm going to talk about are no means exhaustive studies of autonomy in all its many aspects, but microscopic, or let's say medioscopic, if that's the word, views of various aspects of autonomy in these two pretty different places. So first I'd like to talk about in the clinic, in the outpatient setting, where one might imagine that the exercise of autonomy is, so to speak, easier, right? There's less, conditions are often less acute. There's often, a patient is often, is often compos mentis, right, in the clinic. And one aspect I'd like to focus on, because I think it's important and because it might be relatively unrecognized, is that setting the agenda. How are people going to be able to know what is being decided or what they would like to decide upon if people aren't clear about what's actually being discussed? Who controls the conversation? That's something. That's the question that we're beginning to answer, and that, in fact, the whole science was one of the questions considered by the science of patient-doctor communication. That a conversation has drivers and passengers and control, and that basically every moment of the patient interview or the doctor interview, from the patient's point of view, is fraught with potential decisions. This is a clock. But it's here to say that oftentimes people get interrupted. And although we know, and in fact, Many physician organizations and patient advocacy organizations take for granted that it's known that the visit should start off as open-ended as possible, giving the provider the chance to solicit concerns. We know that doctors jump in, right, in as little as, in one famous study, 18 seconds. So what's supposed to happen? We know what's supposed to happen is that, in fact, this is another way in which we can argue against the so-called prophylactic argument. We know that culture has changed so much that when I went to medical school, in which reading materials were provided in cuneiform, this stuff was not mentioned. But we know now that medical students are told what is supposed to happen, right? How they're supposed to act with patients. And this is what's supposed to happen. You're supposed to allow the patient to tell their story. You're not supposed to interrupt. You're supposed to probe to exhaustion. Is there anything else? Is there anything else? You're supposed to set an explicit agenda. So, does this happen? So whether, the first how is optional. How do physicians elicit patient concerns and set an agenda for the clinic visit? So this is an analysis of data from the ECHO study. It's a multi-center trial of HIV outpatient centers, for which the primary aim at the beginning of the study design was to look at psychosocial interactions between patient and provider and how those varied among, in particular, among ethnic and racial minorities. And so this study performed is based on quantitative and qualitative analysis of data from that study. And these are tape-recorded and thereafter transcribed visits between patients with HIV and their primary care provider. These are, in the ECHO study, 4 specialty sites participated. And we only included 3 sites because one of the sites, the visits were introduced by a nurse. We were specifically interested as part of our objectives in agenda setting on the part of doctors and patients. Obviously, agenda setting by nurses is a great topic in itself, but not part of our scope. So we looked at 3 sites. And we looked at, in our analysis, how the visit is open, whether and how providers elicit patient concerns, and whether and how an agenda is set for the visits. So we coded a random selection of 2 encounters per provider. That's 66 encounters total. And these are all patients with HIV, and these are all primary care HIV visits at which multiple topics were discussed. So I want you to get in your head how you think a visit like this should go, and how things should be discussed. So the majority of visits started with a general open question of 66 encounters total. 41 started with, how are you? And we'll talk about what could be the function of that question, what that question might mean to the patient or the doctor. A minority began with a leading question. Everything okay? Doing fine? Doing good? And one question, a fair minority, was a solicitation of concerns or priorities. Is there anything you'd like to discuss in the visit today? That's the person, I'm biased, that's the person whose hand I'd like to shake, but we'll talk about actually there are risks and benefits to using that kind of opening. And the remainder were atypical. There weren't really opening questions. Either things were starting to maybe stress, or, for example, providers said something like, I noticed your CD4 count is up, something. So things that we didn't code in those categories. So then I want you to think, well, once you get that kind of opening question, what would you or your patient, how would you respond to that? So patient response is similarly general, right? In most of those cases, that number is from those where there was an actual opening exchange. That's why it's not a full 66. Fine. And there were minorities specific concern. My legs are hurting me. And then there were some that were in which there was this interrupted sequence, and that the patient really didn't get to answer. And then one of the things that's supposed to happen, I said a few slides ago, is they're supposed to be probing to exhaustion, asking about concerns until you get all the concerns out of the way. And again, we can talk about this in the questions, but there are risks to doing that as well. But this happens a minority of the time. Is there anything else? I'm sorry. So before I get to the next slide, now I want you to think, how often, given what we know about what is supposed to happen about negotiation of agenda, how often are agendas brought up? Just get that number in your head. How often is that agenda brought up by the doctor? How often is it brought up by the patient? And how often is it collaboratively negotiated? So it's like the jar of M&Ms. Whoever guesses. So none, most of the time. And of those that did have agenda discussion, most of those were physician directed. In a minority, they were patient directed or collaborative. So you see the examples up there in which either the patient brought up the agenda item or there's collaborative discussion about the agenda item. What does that tell us? Well, one thing is that generic opening questions don't really solicit concerns. And you can argue whether, so the argument to this is, so when patients respond, they also respond generally. So the question is, how is this opening question received by the patient? And that's not, in our data, but you can speculate that it's more of a social lubricant. Hello, how are you? How are you? Oh, he's asking. It's an opening question, right? When the doctor asks, how are you, and you say, fine, the doctor thinks he has gathered clinical facts when you think you have been polite. So this, I think it's a revelatory quote. That does happen. And agendas are not explicitly stated. When they are stated, they tend to focus on physician priorities. And negotiation of the visit tends to be rare. What do we do then? We should give patients the explicit opportunity to state their priorities. If their priority is, for example, you're the doctor, drive the truck, then I think that something could be honored. But perhaps there are other priorities. And discuss or negotiate with them the agenda for the visit. And again, speculatively or as a recommendation, we need interventions to educate physicians and patients about how most effectively to discuss and express concerns and how to set an explicit visit agenda. And physicians perhaps are not aware or haven't thought about other options or ways to start a visit, rather than asking a general question.
Zack, excuse me, can I just ask a quick question, just for clarification?
Yeah.
Do we know anything about what percentage of these visits are sort of routine well visits versus visits that resulted from a patient having a problem and calling to make an appointment because of that problem?
That's a good question. These are all patients' visits with their primary HIV providers.
Like that they're routinely scheduled?
Follow-up versus new patient, right?
Right. None of these are new patients, I can tell you that. Where the acuteness of the visit is a good question. I can't tell you that. That's definitely something to look at. And one argument you can make is that these are not, in fact, since these are not new visits, a lot of the agenda has already been set. You could have argued in previous visits, right, in the hallway with the receptionist. There's agenda setting going on elsewhere. So that's one thing. But yeah, I think you raise a valid point about the acuity of the visit. So I'd also like to talk a little bit about autonomy in the hospital. And that is an even more fraught area. We know in the hospital things are acute. Time pressures might be even greater than in the clinic. The opportunities for decision for substantive involvement in decision making might be even fewer. And to do that, to understand the exercise of autonomy, we need to understand communication. And the understanding of communication in the hospital itself is not as worked over a field as communication on the outpatient side. This patient and doctor are having a fruitful conversation about aero safety. So in preliminary work, done in Bellevue Hospital in New York, I looked at how patients report of of the physician's reason for admitting them compared to that physician's reason as stated in the chart. And I found that, again, in a small sample, about 10% couldn't give the physician's reason for admitting them for a number of substantive, not throwaway diagnoses. And I also found that discordance among that patient's stated physician reason and the physician reason as stated in the chart was not uncommon. This is one egregious example, which I can go into more detail about that case later. But the patient reported that the physician had admitted them to the hospital because they couldn't speak, and the chart gave the physician's reason as atrial tachycardia. This is a separate study, which is in progress and funded by the Osler Center and the Greenwell Foundation. Looking at 20 patients admitted to the hospital service at Johns Hopkins Hospital with their kind cooperation. And it's a mixed method study, looking at the combination of narrative and conversation analysis and existing communication coding systems. And we're just beginning to code. And our aims are to really characterize communication between physicians and patients in the hospital, determine the exercise of and influence on autonomy as determined by their participation in decision making, look at the nature of relationships between inpatient physicians and the patients, and identify opportunities for greater exercise of patient autonomy through enhanced communication. Because I think one of the grounding philosophies of our study, is that, as I said before, autonomy is in some measure relational. That properly cultivated or acknowledged relationships can help in the exercise of autonomy. What I'm going to do is I'm going to show some transcripts and talk a little bit about the concerns that are raised by these transcripts. And I'll tell you a little bit about how coding is going and what sorts of approaches we're taking. And we're really looking at two broad sets of domains where we code this data. We're looking at exchanges between doctors and patients and how what's said in those exchanges relates directly to decisional autonomy, making decisions, to the plan of care, being involved in the plan of care, to hearing options. And we're also looking to code, broadly speaking, emotional or relational types of exchanges between doctor and patient. For example, my wife, she's going to be a little late visiting me in the hospital because she had to get the car fixed, and the doc says, "Isn't that terrible? I just had my car in the other day. They charged me, $300 for a busted taillight. Can you believe it?" And that was a moment where, put broadly, the doctor picked up on the signal, right? And there was a connection made. So that's another kind of broad domain. So this in particular.
Can I just ask one?
Yeah.
Perhaps related to Ian's earlier question, but are we to assume that these are physicians who are unknown to the patients before their hospitalization? That these are hospitalists rather than the primary care provider coming into the hospital to take care of them?
In this case, they're definitely hospitalists. That's all in the hospitalist service. Future work will be, for example, the house staff service. Whether or not those are doctors unknown to the patient is not always the case, but of course we all know with the current climate of care, it's becoming rarer and rarer for the outpatient or primary provider to admit their patient to the service. So I take your point, but I would say that's what things are.
Oh, absolutely.
Yeah.
Just to clarify that in many cases they're strangers
Yeah.
at some level, and all the more important then to have some relational building.
Yeah,
because they're strangers.
I agree with that. Yeah. And so just to read a little bit, so the research assistant asked in the second half, and what were your feelings about being here and going through the emergency room and everything? And I can't believe they didn't have pencils for me to write numbers down. And this is a discussion elsewhere in the transcript, but just to summarize. And apparently, we weren't there, but to judge from the patient and doctor's discussion about it, the patient was in the ER, and the patient wanted a pencil to write, had a pen to write something down with, given her by somebody or other. And whoever it was or someone else asked for the pen back. And her statement was, "Hopkins has so much money." right? Hopkins has so much money. What? Why? You can't give me something to write with, right? So that was, or maybe it was a pencil. But in any case, it was a writing implement. That was the. And she told me they had to bring their own pencils. And this doctor I got into it because I've been here, and I was a woman, and I told her she was very cold-hearted. Evidently, she must not be a mother or a grandmother or a child of God because to treat somebody like that that's sick. She didn't know me from Adam and Eve. I was just telling what she had to do by the rules, and I was telling her what I'm experiencing, what I'm feeling, and I'm 49 years old. So there's a lot going into that statement, but two things that come to mind is that I think one of the things that she's implying is not just that the doctor is lacking a basic sense of humanity, but that, according to the patient, but that there's a lack of appreciation on the doctor's part of the relations that pertain between people, right? You must not have someone in your life, you must not be a mother or a grandmother or even a child of God, like a sort of a broad possible category to her, right? And this connects to her statement of autonomy, which is, again, right, she's 49 years old. She's not 5, right? She's not a child. And so connecting, I think, very directly these two domains of you're not seeing me, right? You're not appreciating, you are not using your innate human knowledge of relationships to see where I'm coming from. And thereby, I don't feel like my age and experience is being taken into account. This is a less dense example, but as interesting. Have there been any changes since we last spoke about the plan of care? Yes. Yesterday they told me I was supposed to get an MRCP. Today they told me they want to give me a CAT scan. And then a woman doctor came in this morning with another man and said, all right, you're going to be drinking a barium solution, which is what I've done in the past. And the third party with the mother said, with the cat. Yes. And then I wake up and everybody in the world is here and the doctor say, no, you're not going to drink anything. You're just going to get an injection. I have no idea what they're talking about. So what I think this is, besides the plain meaning, right? The patient has no idea what they're talking about, which is obviously of interest. There's other sense that Martin Schmidt, if I pronounce his name wrong, which I usually do, the bioethicist from Holland who wrote a book about autonomy in the hospital they referred to, and a lot of decision-making isn't made in the room, right? So there's no possible way that the patient can actually be involved. They didn't stand around the patient's bed. Well, they might have, because we didn't see what happened, but oftentimes it's not that Dr. 1 is saying to Dr. 2 with the patient present, we should get an MRCP or should we scan him? And they say, well, we'll just scan him. Oftentimes it happens through emails, through phone calls, in the hall, in someone's mind, right, outside the room, but outside the room. And this is the final transcript. I'm gonna show it today, but these are just to give you a sense. These are excerpts of and we, as I said, we're recording rounds on a daily basis. Where the hospitalist goes into the patient's room to talk to the patient, we're recording those every day, and the third parties in the room with their consent, obviously. And rounds on the hospital service are not as an institutionalized educational endeavor, though they can be, as on the house staff service, but they happen at different times of the day. And we're also interviewing, again with their kind permission, patients on a daily basis for their hospital stay and asking them questions about their part in the plan of care and whether and how their views are taken into account in that plan of care. And then we're also interviewing physicians, the hospitalists, again, without their time, this wouldn't be possible at all, who we ask questions about the plan of care for the patient, whether they think the patient understands, whether they think the patient has been given an opportunity to participate in the plan of care. And so recording, even just for an N of 20 patients, recording all these things over multiple days is a wealth of data. So this is the tip of the iceberg. How do you feel specifically today about how the doctors are involving you in decisions? I feel like I'm not really involved at all, unless I say I want to talk to my specialist and then everything gets put on pause. And do you wish they were a bit more involved? Yeah, I wish involved with communication. Maybe you should start writing stuff down, Mom. Somebody should start writing stuff down, what they say. So again, there's a place here in which the patient is able to have an influence on the plan of care, right? They know how, they know which lever to push. But otherwise they don't feel involved at all. They have to take an active You have to stand up for the history, right? They have to stand up for the plan of care and say, stop, I'm going to call my specialist. And they also would like someone to start writing stuff down, right? Not them, right? Their mother. But someone maybe that's paying attention. So again, these are preliminary results, and these aren't real results. They're transcripts, and we haven't. The real interesting part is coming in, looking at the domains and how these domains interact, and it's going to look at. Then we're going to be looking at how these exercise of autonomy, relational or decisional autonomy, is related to the communicative practices of the doctors, which we'll do using widely used coding methods such as Rios coding. But in encouraging the exercise of autonomy in the hospital, what would we do? We could educate, and I think should educate house staff as tending to recognize opportunities for empathy, and in so doing, I think encouraging relational autonomy. We should create opportunities for patients to discuss their second-order preferences. Perhaps when a patient comes in, find a way to ask. And I think this has been done. Would not be an entirely novel thing. There's some, in fact, outpatient practices where this is done, to ask patients, what kind of a role would you like in your decision making? What sorts of things do you want input in? Or how do you want doctors to make decisions? And people are given vignettes or lists of alternatives. And recognize the variety of patients' approaches to decisional autonomy. So I'd like to end with acknowledgments and then answer a few questions. So it's it takes a village to communicate or something. So first I'd like to thank, besides my funders, who I mentioned already, Mary Catherine Beach, who's a wonderful colleague and mentor, Dan Brotman, the head of the hospital service, Heather Dark, my research assistant, Amanda Bertram, who helps coordinate research in general internal medicine, Maggie Neely, a nurse manager of the hospital service, and all the physicians and patients and nurses in the hospital service who tolerate weird outpatient internists or on their hallway. And thank you for your attention, and please. Can
I just ask, just out of curiosity, in any of the interviews that you've done, whether the physicians have a sense that they are involving patients, or do you have a gestalt about their own beliefs about how they're incorporating patients into decision making?
Yeah, and that's why we're interviewing the doctors. And I think there's a range, but no one so far, and it's, we're going cold because of the few, has said, actually, yes, I've thought quite a bit about this, and I give patients every opportunity a chance to exercise autonomy. That's why very few people say that. But very few people, on the other hand, say, that's ridiculous. I'm the doctor of the patient. A lot of people say, several people have said something like, yeah, I do. When I do take their wishes into account. For example, this has happened more than once in our transcripts. When the patient is feeling nauseous or in pain, I really depend on the patient to tell me that. Without that, I don't know what's going on with the patient. So that's very interesting. The physician needs the patient's symptomatic report, right? So that's part of it. And then another kind of response, which is frequently given, is, yes, I know they're involved. I know they've been given a chance to be involved because they understand everything. And then we have another question: how do you know they understand? And that's another array of interesting responses. But one very interesting response is, I know they understand because body language, because of the kinds of questions they ask. So there's various, when you ask, it seems, at least in this, when you ask the physician, are they involved? There's certain tracks people's responses go down. And they very much go down how patients' symptomatic reports are important to the plan of care.
Yes, John, please.
So, to me, autonomy is different than involvement, is different than, for example, voluntariness. So I chair the IRBs, of course. As you were talking, I'm thinking sort of the parallel construct for human-centered research. I guess what I'd like to know is on the spectrum from complete autonomy to complete paternalism, how do you decide where we ought to be operating? Because there's something implicit in your whole presentation. There's an ought that's actually implicit in your presentation that I'd like you to make explicit and justify.
I like that. think I would say there's a modified law, and that is in certain situations, for certain patients, there's a range of the exercise autonomy which one should expect, or which one should strive for or try to attain. But I think one of the major points is in appreciating the importance of a principle, one does not necessarily accede to the principle being exercised at the same magnitude and the same strength for every patient and every situation, right? So I can't tell you there's always the same ought for every kind of autonomy, for autonomy over all PD, right? Or all procedures, or all patients, right? I can't say that, right? I can say for a given range, right? And maybe that should be, thinking about it, maybe that should be the first stage of any consent form. A consent form talking about the procedure and the risks and benefits, but the first stage should be, well, this is the kind of thing we're going to talk about. What involvement do you want, right? And of course, people are doing this, right? People are talking about this. What kinds, and that's how we should estimate what sort of range we'd be talking about for autonomy. And it could be that if someone falls outside of that range, we're either talking to a surrogate, or we're talking about someone that's not in a place to discuss the procedure in a way that might satisfy requirements for consent. But we're not going to be able to say to everybody, you need to exercise autonomy up to level this, or otherwise, you're off the island. Yeah, so the short answer is, yes, there's an ought, but it's always different, or often different. And it depends on whether you're a splitter or a lumper, right? Also. Yeah.
I appreciate this concept a lot. Again, this is another question sort of about the plot. And it seems like, in hearing you discuss this, it feels as though you're elevating or giving respect to autonomy sort of above other aspects of the duties that physicians have toward their patients and other principles of ethics or whatever. And it seems sort of like a beginning or an elevated principle. And I spend a lot of time with residents hearing them talk about how they're trying to balance their duty to respect autonomy with their duty to avoid harm and all the other things. And I wonder, in your research, how you accommodate that autonomy is one of many principles, and the balance is sort of what it is.
Yeah. I think autonomy is what I'm talking about. It doesn't mean I'm elevating above other principles, right? So there's a lot of principles to be considered, and I think autonomy is especially interesting because I think some people do elevate it among other principles. And as to how to balance that, I think that's an important point. That's something to consider when we look at these transcripts, is how people are balancing various principles and various commitments. I don't have a ready answer, but I think to have in mind the concept of balancing as we look at these data is going to be very important. And I think it's also important, as I speak to residents too, and it's also important to keep people in mind that it's not just autonomy versus paternalism, right? There are lots of axes, right? And that's not the sole axis. And I think people tend to fall into that trap, and I hope I haven't.
A lot of people come to John's office to hear the #1 hospital in the country tell them what to do. So I work with a group of patients who are here for an all-day visit. So how can I introduce in the beginning of the day what our expectation is, or how we would like them to participate in it, so that at the end of the day, I don't have them look at me and say, so what do I do?
Yeah, I had a patient in a similar setting who said to me, so what do you think about all this best hospital stuff anyway? That's a subject for a different topic. I think maybe one part of it, this is where Schneider's book was very helpful to me, is look at it in a therapeutic way and say, for you to get the best care, we need for you to give us a real sense of where you stand with various things. And that's a complicated discussion because for some people it requires taking the doctor off his or her pedestal, right? And saying, we're not actually, we're actually sublunar beings, right? We don't have our finger on the pulse of every possible great decision. And so you're going to have to make your voice heard, right? And that's personally how I go about it. What the literature says about the best way, and I think that shows just how what's what's lacking in the literature about the connection between communication practices, encouraging these sorts of things, and outcomes. Like, what gets a patient to a good place, right? You know, is it if a patient is the type that wants to be told what to do because they're coming to Hopkins sitting on a hill, right? Is that going to get them in a better place than if we say, well, you're at Hopkins, welcome, and we're happy to see you, but, you know, we need your opinion. Which of those is better, right? But that's how I would do it personally.
So I want to follow up on that a little bit. I think part of what complicates this whole situation is in how we're defining autonomy. Because if you think of autonomy sort of the way Carl Schneider does as sort of deciding, I would think that's a lot harder. That's a much higher standard to expect of patients, and I would agree, something you would never want to mandate. But if you think of autonomy as values clarification, we may want to do a little bit more than just encourage. I mean, we may want to try to insist to the extent that we can that we have some knowledge of what makes this person tick, because you have to have that in order to provide good care.
Yeah.
And that's a very different requirement of autonomy than deciding what to do.
Yeah, I agree with that. I think my question would then be, how do you know what makes a patient tick? And I think about Ansel Mass's work about, is values clarification the best way to get there? And then you run into the complication that a lot of people can't clarify their values at all. And so then the question is, how do you know what makes a patient tick in a value-based way? Is it through, I think as he would say, narratives, about difficult end-of-life situations, for example, what decisions people might make in those situations.
I just think autonomy, holding a standard of having the patient decide is a very high standard.
Oh yeah, well, and I don't claim to have represented that standard. I do claim to want us to pay attention to how relations between people affect autonomy. Where autonomy can be interpreted as having to decide, or it can also be interpreted as decisions about involvement, right, level of involvement. And I want to know what makes the patient tick, but I guess I'm skeptical about values as a way to get there, knowing what people think about values, which, and for many people, tends to be not much. Not that they don't like them, they just, don't express it.
Just moving this way.
Sorry.
Catherine, and then over there, and then Michelle. Thank you.
So I had a couple of thoughts as the discussion was going around. Just say one of them maybe. The issue of raising autonomy above other considerations, I think for your project isn't as much of a concern because there are not a lot of conflicting values here. So there's no well-being argument to make for a person sitting in a hospital bed not knowing what's going to happen to them in the next hour. So there's, in some respects, you could say it's a matter of autonomy to have some sense of control as much as you possibly can, and then perhaps that means information as much as you possibly can. But I don't know that there's any other argument to be made for. So I don't think it conflicts. And then the other point is that the degree to which you're involved in this, you may not have much of a choice to be involved in decisions. Many times if someone comes to the hospital, it's sort of one of those situations where you often are admitted for a problem. You have essentially said, please help me with this problem, and now everybody's trying to figure out the best way to help with the problem. There's not a lot of involving patients in decisions all the time, although probably there are many small ways in which we do or we should. And so I guess it depends on I think what you'll have to do when you really analyze your data is look at the context of the patient's admission and how much involvement might have been reasonable.
Right. In fact, there are many statements where the patient says something like, I just want everything to be done, right? I just want everything to be taken care of, right? And even when we ask them, right, if you have a role in decision-making or your plan of care, I just want everything to be taken care of, right? And because they're here for the problem. Yeah.
So I won't pursue that very much because I think I gets into the issue of choice versus control as part of the subject. But my question for you was going to be, it strikes me that what you described is suffer and be less important in what I call scripted care, as in surgical procedures where a care plan is laid out, a roadmap. Today you're going to do this, and tomorrow you're going to do this, and the following day you're going to be ready to go home. Is that kind of homogenized care, which even in medicine is what we're going to more and more, going to reduce patient autonomy as you see it?
Right. I remember as a medical student doing 55, post-ops in women that were postpartum, and at 4 a.m. And then we got a sheet, right? Post-op day 1, you do this. Post-op day 2, you do this. And when you got to the room, and the patient said, actually, I'm having pain over here. And like we were checking the sheet, like, wait. It says nothing about that on post-op day 4, right? You're supposed to be up. Like, I don't know what your problem is. Yeah, I don't have a good answer to that. The intuitive answer is yes. These scripting encounters tend to minimize those chances. But I feel like, I'm finding things in the data that I didn't expect before, so perhaps if we were to look at those sort of encounters, we might find that as well. And then I guess the corollary point is that in the hospital, it tends to be less, broadly speaking, a primary care environment and more a specialist-driven environment. If I could think that way, especially, I think, in certain circumstances of hospitals, right? So that might be part of that as well. That's a good question. That's my intuitive answer.
Michelle.
So I've been listening to you talk about autonomy and the relationship with involvement, but then I've also been thinking about the relationship of involvement of patients' decision making in relation to the standard of care.
Can you expand?
So I guess I'm thinking about at what level do you, or would you recommend that you limit patient decision making when what they're asking for is something that they don't want to undergo an uncomfortable procedure, even though it's the standard of care. And so at what point would you just say, okay, if you don't want to do that, that's fine.
Right.
Or versus pushing them, saying, this is why it's really important that we do this.
Right. That's a great discussion. There was a great article in Annals, Animal Journal Medicine, I forget who, but someone pointing out that when we're driving for quality of care metrics, we want 100% of people with diabetes to get their A1C at a certain time, right? Or we want 100% of women in the eligible age range to get their mammographies, right? Well, if they don't want to, right, that takes away from our bottom line. I think that happens all the time, right? There are plenty of times where a physician says, I'd like to talk to you about smoking, and the patient says, I got it under control, doc, don't worry. And you're like, all right, and that's it. So I think that balancing happens so often that maybe we're not cognizant enough of the actual balancing we're doing on a theoretical basis. So how to make those balances explicit is something I haven't thought enough about, but I agree it's something we need to do. I just know it happens all the time, right? I need to tell you, sir, that you should be undergoing colon cancer screening. That sounds awful. Can we talk about that next time? Yeah, or you push them and they say no again, and then you just hear it. So all the time, right? Every visit. So.
How do your colleagues feel about this study?
They love it. I presented it to my division of general internal medicine, and it was a very nice reception, and I got a lot of good questions. Again, this is a lot of what College Schneider talking about in his book about the paternalistic attitude of doctors is very much changed, at least in certain quarters. Does that answer your question?
Well, I'm an anesthesiologist myself, and I found that anesthesiologists would not be interested in this very much.
Right. Well, I need to tell you, I'm in general internal medicine, right? How more granola can you? Well, you can get more granola, but these are the people you would expect to be interested in this sort of thing, right? And bioethicists. So,
We have time for 2 more questions there and there, please, and then people ask, please.
I was just curious about the legal framework and care of doing from positional as you increase autonomy, patient autonomy. Because I can imagine that a physician would want to suppress patient decision making when if you explain the process of what chemotherapy is as
So you're saying, are there cases in which physicians' natural tendency is to suppress various aspects of patient decision making because they're very concerned about clinical outcomes? Yeah, and empirically, yes, there is. And that's why, just my intuitively, I think these discussions maybe happen less often in the ER, right, or in acute care situations. But the legal framework, I'm not. I don't know how I understand, how I see how that fits in. I think it's obviously an important consideration, but I'm not clear on how to answer it.
So we have one more question, please.
Yeah, this is not your study, but this is just something I was thinking about when I was imagining the situation, which is that I would love to know how money plays into where people exercise autonomy. Because I live on the opposite side. I'm a veterinarian and nobody has health insurance. Every test and every image, every treatment comes with a dollar sign. And owners want to ask a million questions. They never want to hear a decision. So I don't know, I can't think of a human situation where people have very financial stakes in the decisions, but it would be fascinating to look at how that affects who takes charge.
Yeah, I mean, there's a literature on this. There are clinics now that are testing a sort of a dial on the electronic medical record to see how much things actually cost, because that information is often hidden to us. So I agree that's